papers produced by the Shock ED group, the sonography and hypotension and cardiac arrest in the emergency department, which I think is a Canadian group that have focused on this topic. As always, I'll preface this by saying I'm not the world's greatest academic, so please pipe in whenever you have anything to add. The studies that they produced in 2018, 2019, the first study that we'll go through is, does point of care ultrasonography improve clinical outcomes in emergency department patients with undifferentiated hypotension? The second study is, do combined ultrasound and ECG rhythm findings predict survival in emergency department cardiac arrest patients? And the third study is, does point of care ultrasound impact resuscitation length, rates of intervention, and clinical outcomes during cardiac arrest? So we'll start with study number one. So does POCUS improve clinical outcomes in ED patients with undifferentiated hypotension? So as we know, there's some evidence demonstrating that the use of POCUS does improve diagnostic accuracy and undifferentiated shock and can improve the timing of critical interventions. But the authors promote this study as the first RCT to examine patient-centered outcomes of the use of POCUS in these circumstances, for example, mortality. So they performed a randomized controlled trial, an international randomized control trial at 3 tertiary centres in North America and 3 centres in South Africa, ranging from tertiary centres to a district hospital. Each of the centres had emergency physicians that were trained in the use of POCUS, and they did some work to ensure that level of competency was fairly standard across the 6 centres. They recruited patients over a period of 4 years. They sought to perform a randomized controlled trial examining POCUS versus no POCUS in patients with undifferentiated shock, unblinded. They used convenience sampling in that they recruited patients at the times where appropriately trained emergency physicians were available to perform the POCUS exam. There was computer generalized randomization, and each centre was provided with sequentially numbered pre-randomized envelopes with good allocation concealment, and patients were randomized to have either POCUS or no POCUS during their initial assessment in ED. Their inclusion criteria were patients aged 19 and over who were hypotensive, either with a sustained systolic blood pressure of less than 100, although they didn't define exactly what sustained meant, or a shock index over 1 with a systolic blood pressure of less than 120. They excluded patients, including pregnant patients, patients who had undergone CPR, trauma, ECG diagnostic of myocardial infarction, or if there was a clear cause for shock that was immediately identifiable, patients with vagal episodes, or patients with non-pathologic low blood pressure. The purpose of these exclusion criteria really was to create a sample of patients in whom the shock was truly undifferentiated. They assessed a total of 347 patients and recruited 273, and they had similar baseline characteristics. So what did they do? They randomized patients either to have a POCUS examination within 60 minutes of arrival following the initial physician assessment, or to no POCUS, just normal physician assessment. There was a standardized protocol, which we'll go through in a moment, and standardized documentation to record the findings of that examination. And the initial diagnosis and other clinical data were recorded immediately after the initial assessment, and then at the 60-minute mark in both groups. So the standardized protocol that they used was kind of similar to a rush protocol, or with some elements of other protocols. And essentially they wanted to look at the heart, they wanted to look at the lungs, looking for pneumothorax or pleural effusion, and they had a look at abdomen, pelvis, specifically looking for free fluid, not for any other abdominal pathology, a look at the IVC and the aorta. Their primary outcomes were survival to 30 days or to hospital discharge, and secondary outcomes that they measured were the rate of inotrope and IV fluid use, rate of CT scanning, the admission rate, and the length of stay. So What did they find? The final diagnosis in this group of patients with undifferentiated hypotension, just over a majority were occult sepsis. Another proportion was severe dehydration. MI took up 8%, and then there was a variety of other diagnoses to explain the hypotension listed. What they found was that in the patients who had a POCUS examination versus the patients who did not have a POCUS examination, there was no difference identifiable in 30-day survival or survival to hospital discharge, and absolutely no difference in any of those other secondary outcomes that they were measuring. This is their result here, which, as demonstrated, there's no significant difference between the groups. So thinking about this trial, there's a few strengths and a few limitations, and then we'll go on to discuss what we can really glean from this study. They did seek to measure clinically important patient-orientated outcomes, which is really what we do care about. There was no significant loss to follow-up, really good allocation concealment, and they had created two groups that had really similar baseline demographics and vital signs. The trouble they had is that they had quite slow recruitment in this study, and that was partly attributed to a lack of appropriately trained ED physicians who could perform those POCUS examinations. So it took a long time to get reasonable sample numbers. Their goal was 400, and they wanted to detect a 10% relative reduction in mortality, assuming a 30% mortality rate in this group of patients. They were terminated at 273 due to that slow recruitment and to perceived futility when interim analysis showed that there was no difference between the two groups at that stage. They did note that some of the POCUS protocols were not thoroughly completed, and they did note that the ultrasound images weren't stored for review, so there was no real quality control or comparison to gold standards. So this is interesting because they really did a good job of seeking to identify that group of patients where they were truly undifferentiated shock. But that meant excluding a large group of categories in whom rapid POCUS diagnosis might have actually demonstrated a survival benefit. And so those groups were the groups where POCUS is becoming standard of care. So some early pregnancy with severe abdominal pain and shocked, it's almost standard of care to pop an ultrasound probe on to have a look for free fluid, and would not be ethically correct to randomize a patient like that to no POCUS. They also excluded patients where there was a clear or obvious mechanism. So that can be, the patient having a massive upper GI bleed. But I guess it's also a little bit of a grey area of whether you describe someone, for example, with, a full leg plaster cast and no DVT prophylaxis who arrives with chest pain and shock. Is that an undifferentiated shock, or is the reason for that patient's shock immediately obvious? And those patients are patients in whom POCUS may show a survival benefit. The other thing to think about is that in that group of patients with truly undifferentiated shock, the kind of pathology that POCUS identifies and might show a mortality benefit for us are quite rare. So, of their 280 odd patients, they showed only 7 patients with PE, 2 patients with aortic pathology, 1 patient with attention pneumothorax, and 2 patients with pericardial effusion. So we're not really identifying a huge number of patients, which may have sort of skewed the results to showing no mortality benefit. As we know, sepsis, there are a huge spectrum of fairly non-specific ultrasound findings. Whether that, so how can POCUS really show a mortality benefit in these? It might guide things like fluid management, but as we saw in this case between the POCUS group and the no POCUS group, there was almost identical fluid administration between the two groups. Another question that was raised by one of the reviewers of this study was, are we really testing the right outcome, and should we really expect a diagnostic tool to affect mortality? Would it be, is it more interesting to really think about how the use of POCUS changes the diagnosis or changes our immediate management? Did anyone have any thoughts about this study or interpretations?
Interesting study, Elise, and I see lots of issues there, from sample size calculation, the mortality difference between South America and South Africa and North America, patient cohort. Why did they choose 10% difference? That would have affected, the sample size. And second, it's very, like, in principle, it's very hard to study or create a study like this by randomizing, which ethically, as you mentioned, you're denying during the randomization some patients. So we as a group obviously believe every patient with in-shock requires an ultrasound echo. So yeah, there are huge issues, and there are sort of minor issues, huge issues outside, including the ethics, and then the minor or smaller points about how the study was conducted methodology-wise.
Yeah, Elise, is this where was the demographic of this study in the sample? Sorry, which country?
North America, 3 centers in North America and 3 centers in South Africa.
Did they read on POCUS guide their differentials, or did the physicians doing it already had a set differentials to exclude with POCUS? It's not, it truly undifferentiated. The pathologies that POCUS identifies are rare. It's not, you're not relying on POCUS to tell you this is it. It's like, as a physician, you need to have a true range of different need to exclude in that for the patient. I don't know whether they tailored that, or is it just this protocol is going to identify all of these common causes, and I'm just going to methodically doing this. Thereby, I don't know, I think there's some, you can't just generalize a protocol to a undifferentiated, I guess, yeah. So Ebra is saying some important stuff too, yeah.
True.
Yeah.
All
Then,
true, very complicated, but it was used by opponents to ultrasound saying, hey, you see, it doesn't make a difference.
Yeah, it's a common thing that they use to sort of deny the utility of ultrasound, like mortality outcomes. In reality, I think I agree with that last point. Like you said, like at least someone in that article mentioned, are we testing the right outcome? Which I think is true, because yeah, it's very hard when like mortality depends on so many different factors in a patient. Just picking up a diagnosis, I mean, hardly ever sort of affects your mortality, because there are multiple ways of picking it up. It's the utility for us is the speed with which we impact on the diagnosis, as well as the management and the disposition of the patient. Those are outcomes that I think ultrasound helps a lot with, rather than waiting for a different definitive imaging study and things. So I think to then convert that into an outcome as to whether ultrasound really did make a difference is very hard. So it's one thing that the opponents of ultrasound use a lot. And I think they'll continue to use this a lot. I think there's not much you can do about it. I think in the end, we just have to keep like persisting and try to turn the focus of the research around to other outcome measures rather than just purely mortality. But
I agree.
Yeah.
And I think you're right, Abra. Like, they wanted to have a really patient-centered outcome to measure, but I don't know that mortality is really the right answer. And you're right, Abra, by saying how if this speeds up your diagnosis and speeds up your disposition decisions, then that is good for the patients. They're not loitering in ED, starving on a trolley in the corridor for 7 hours waiting for another diagnostic modality. If something can be diagnosed and then they can be moved to the ward or referred to the surgeons, and that is a good patient-centered outcome that
Yeah,
Yeah.
like it affects things like time to antibiotic, time to interventions, all those sort of things, which will then impact on mortality down the track. But
yeah,
you know,
but
like
via several steps.
yeah, that's right.
Yeah. All right. So that is this study. Let's move on to the next one. So this next study is the question that they're asking is, does a combination of using ultrasound and ECG rhythm findings predict survival in cardiac arrest in the ED? So background being that, as we know, the use of ultrasound is not included in our current ACLS protocols, but it's practically used quite often during those rhythm checks to take a clip of the heart to see if there is mechanical cardiac activity. And there has been some studies demonstrating that the presence or absence of cardiac activity is associated with outcomes. And so what they tried to do here is to assess whether using a combination of ECG and ultrasound better predicts the outcome in cardiac arrest. So what they've done is a retrospective review of health records in a single tertiary centre over a 4-year period. They included all non-traumatic cardiac arrests and excluded age under 19. They excluded patients in whom the initial rhythm is shockable. So we're talking about non-shockable cardiac arrest. They've excluded cases where resuscitation was ceased due to end-of-life decisions or where no POCUS was performed. So it's really just that group of non-shockable cardiac arrest where a POCUS was performed. And they want to look at the use of the ECG rhythm and the POCUS outcomes and how that predicts whether or not patients got ROSC or survival. And so they looked at a total of 180 cases. The data that I collected was the initial ECG rhythm, whether it was asystole or PEA, and whether or not there was cardiac activity on the initial ultrasound. The primary outcome was failure to achieve ROSC, and the secondary outcomes are failure to survive to hospital admission and failure to survive to hospital discharge. There's a lot of negatives in this study, which I found a little bit mind-bending. But here are the numbers. So this table I found a little bit messy to get my head around, but what we're really focusing on is this bottom block here. We're talking about POCUS, so where the patients had asystole on their initial rhythm. They've got cardiac activity, no cardiac activity, or cardiac activity, and then whether they got ROSC or no ROSC or ROSC. Survival to hospital admission and survival to hospital discharge. And then a second PEA group here. The first thing I think when I look at this table is that the outcomes, survival to hospital discharge, are dismal, which I think we probably knew. But we'll talk about now what their results were in terms of their sensitivity calculations on the combination of these two examination findings in predicting failure to achieve ROSC. So I'm keeping an eye on the chat here as well. Yes, Jono, asystolic patient with no cardiac activity survived to hospital discharge. That's right. And that's one of the questions that we need to raise in this. Is ultrasound good at identifying difference between asystole and fine VF? But interesting also, asystole plus no cardiac activity, 21 of those patients out of 129 got ROSC, which is kind of wild to me. So here is the outcome. I've stolen this graphic from a reviewer. So the sensitivity of ECG alone in predicting no ROSC, i.e. dead, so the condition we're trying to assess is dead, is 83%. Ultrasound alone, sensitivity 96%. Where you have a ECG showing asystole and no cardiac activity, we've got a sensitivity of 98%. in identifying dead. And in PEA and no cardiac activity, we've got a sensitivity of 87% in identifying dead, i.e. no ROSC. The specificity of these is quite poor. And the summary of this is that POCUS is better than ECG in predicting futility. POCUS plus ECG is better than either alone in predicting futility, but no combination is particularly good at predicting ROSC or survival, so poor specificity in all of these tests. So it's all well and good to say that POCUS plus ECG, so if we have no cardiac activity on POCUS and we've got asystole on our first ECG, that this is highly sensitive for death. But my question is, how does this help us if of those 129 patients who had that combination of no cardiac activity and asystole, 21 of them did get ROSC. So how does that help us with our decision-making in deciding whether to end resuscitation? And I suppose that's one of our discussion points, is that this is part of the picture. So in all of these decisions about ceasing resuscitation, it's not just going to be about the ECG and the POCUS. We're also thinking about the patient's comorbidity, the patient age, what else is going on in the resuscitation. Yes, Abra, as you say, futility depends on other factors, not just the ECG and the POCUS findings. Does anyone have any thoughts on this study? Obviously, there's many limitations in this kind of study. Being that this is also a single centre retrospective chart review. This is because it's retrospective, there's no quality control over the records or the quality of the POCUS, and there's no review of what was actually found on ultrasound. I
was just going to say, Elise, I think this study is really interesting, but it's funny how like every paramedic I know has a story about someone found in asystole who walked out of hospital, neurologically intact, even though it's wildly unlikely. Yeah. So based on 129 patients, one survived to discharge. Like, it's so hard to quantify whether or not it's worth continuing, like what's the value add? And this is in ED. I'm assuming mostly witnessed arrests then. I think
there's some pre-hospital as well.
Okay, all right. But really? So it's not excluding pre-hospital, it's all in?
No, I don't think it was excluding pre-hospital.
Okay. Well, that's interesting, because I wonder when they're going the initial POCUS, I also wonder about the timing of that. Like if the patients...
Yeah, the initial ECG and the initial POCUS are, and I think they did point that out as a limitation. That
if they're 20 minutes apart, then how can you really correlate those two things?
Exactly. I just found this this study difficult to get my head around, because we think about sensitivity for a test in identifying a condition, and the condition they're identifying is dead. Right. And I think we know that if you've got asystole and no cardiac contractility whatsoever, that's probably going to be pretty bad. But I don't think that's necessarily helpful in helping us decide what we're doing next, because yes, seem to be some people who survived that according to their data. But so many other factors come into making that decision.
Like you say, I'm just so surprised. Like, if I see a patient with asystole and no cardiac activity, I probably will be, obviously factor in all these things Abra's listed, but you're probably fast tracking towards ending the resuscitation. I'm just like amazed. The 21 got ROSC. That's basically unbelievable.
Yeah, that's right. And that's why I sort of wonder, like, is that really what they were seeing?
But
This
do you
is
know,
where
guys, like,
quality control happens, isn't it?
Yeah,
Quality
exactly.
control is important.
Yeah, the interpretation of the ECG and also the interpretation of the ultrasound findings.
the fascinating thing for me is like I can't tell you how many times we get ROSC on asystolic patients that, you know, borderline should have never been started on, and you go, oh, this is definitely ending. Like, we're going to do 30 minutes and then we're going to stop. Patient's been in asystole the whole time. And then you go and talk to the family and go, all right, guys, we're going to cease. And then someone comes and taps you on the shoulder and goes, oh, the patient's got ROSC. Like, we've stopped CPR, but the patient's now got ROSC. That happens often. So it doesn't really surprise me that they're getting ROSC on asystolic patients, but it's hard to comprehend that someone walked out of hospital after that.
Yeah, I had a patient a few years ago that got ROSC after an asystolic arrest, and she had a PE. We thrombolized her. She got ROSC, and then she went to ICU. I wouldn't say she walked out of the hospital. I think she more likely she was wheeled out. She actually told me later in ICU that I wish you had not resuscitated me. And this was a 50-year-old woman. I was a bit shocked. I was like, you know, at that, I was a registrar at the time. And it was one of those rare cases where I was involved in a case and then went and did an ICU rotation afterwards. So she basically said, yeah, she asked who was involved, and when she found out it was me, she asked to talk to me and said, you should never have resuscitated me. You know, and this was a 50-year-old well woman. I think her complaint mainly was because ICU was so horrific for her after she got resuscitated, that all the interventions that happened and everything, she said it was much better off to be dead. So that's a patient perspective for you.
Yeah, that's really tough. All right, let's move on to the third one. So, does point of care ultrasound use impact resuscitation length, rates of intervention, and clinical outcomes during cardiac arrest? So they basically use the same data set as the last trial for this one. So again, it's that single tertiary centre over a 4-year period, including all non-traumatic cardiac arrest, except this time what they've done is they've included the patients that did not get POCUS. So non-shockable rhythm, adult patient, non-traumatic cardiac arrests, some of which 880 of whom had a POCUS assessment during their arrest, and 43 that did not have a POCUS. And they're seeking to examine whether or not there is a difference in outcomes between those two groups, the POCUS and no POCUS groups. So today, as I said, divided between no POCUS group, 43, and the patients who had a POCUS, and they've divided that group to those who had cardiac activity, 21, and those who had no cardiac activity, 159. And they've attempted to measure primary outcomes of length of resuscitation, frequency of interventions such as intubation, adrenaline administration, defibrillation, pacing, etc. And their secondary outcomes are ROSC, survival to hospital admission, and survival to hospital discharge. Trying to see if the use of POCUS has altered those outcomes. So what they found in terms of resuscitative effort, which was their primary outcome measure, does cardiac activity on POCUS, so cardiac activity seen on POCUS during arrest is associated with longer mean duration of resuscitation. So they averaged 27 minutes of resuscitation with positive cardiac activity on POCUS, compared to 14 minutes on the patients who had no POCUS, compared to 11 minutes on patients who had no cardiac activity when POCUS was done. There were higher rates of intubation in this group and higher rates of epinephrine administration. The clinical outcomes they looked at, cardiac activity on POCUS is associated with a higher rate of ROSC than both of the other groups, and a higher rate of survival to hospital discharge compared to the patients who had POCUS demonstrating no cardiac activity, but there was no obvious survival advantage to the group of patients who did not have a POCUS examination. So limitations, many. Again, as we know, it's retrospective, observational, non-randomized study. It's really pretty impossible to infer causality here. There are a lot of confounders. They're reviewing old charts, so charting quality couldn't be controlled for, quality of POCUS couldn't be controlled for, and sounds like there were variable delays until the initial POCUS, as we discussed in the last study. So in their discussion, they suggested that could it be that emergency physicians provide increased resuscitative effort for patients when they've seen cardiac activity on the POCUS? So that's a difficult question to answer, and I don't think this study answers that question. Does POCUS simply identify those patients that were more likely to survive for many, many other reasons, as we've discussed? Difficult to answer that question. Does anyone have any more comments about this one? So one of the things that I also thought was interesting was that that looking at the no POCUS group versus the POCUS with cardiac activity versus the POCUS with negative cardiac activity, they're saying, look, essentially, this group with positive cardiac activity on POCUS is better than the no POCUS group. But really, if you think about this no POCUS group, it's just going to be a combination of people who either had cardiac activity or didn't. So it's probably sitting somewhere as an average between the other two groups. We just don't know what they had. So it's pretty hard to compare their outcomes to this POCUS group. Does that make sense? I don't think I'm explaining that very well.
No, you are actually. You're right. It's not very well. The methodology is not right. It's
No.
not very clear.
Yeah.
We don't know what exactly is in that group. Huh?
Exactly. And again, it's trying to link a kind of diagnostic tool with outcomes. Again, we don't know that that's the right thing to do.
It's a step. It's a building block towards the final evidence in a few years' time.
Yeah, that's right. So I did last night when I was just sort of doing a final bit of reading around this. There is another trial that I only had a really brief read of, which I think sort of tried to mimic this trial, well, was sort of in a similar vein. So is detection of cardiac activity on POCUS in patients with PEA or asystole associated with improved survival from cardiac arrest? And this is a much bigger study. It was a prospective, protocol-driven study of 7 with quite a good sample size there. And they found that cardiac activity on POCUS was associated with increased ROSC and increased survival to hospital discharge. I haven't looked into this paper at all thoroughly, but it would be an interesting one to look at.
Thanks, Elise. That sounds very good. Thanks. You've done a lot of work with these trials. They're not easy to read.
No, I
get through. So yeah, it's, I used to struggle with these like literature reviews and things back when I did the rotation. So I think you're doing a really good job. I think it's quite a good learning activity just to see what's out there as well. So that's good.
Yeah, it's a good learning activity for me. As you all know, I'm not the greatest academic amongst us.
Neither am I.
Great work. But if you guys look at these sample sizes, when they looked at 5% in one of the studies difference, so the calculated number of patients were 170 something, and then when they looked for 10% difference impact, the calculated numbers were 400. And I was mentioning earlier to Elise, I'm not the best, in understanding that either. So that requires a bit of better understanding for biostatistics. And I do believe that, generally speaking,